Mo Mhatre. How are you doing, Mo, today?
Hi, great, Vincenzo. Nice to see you. Hi, everyone. I'm Mo Mhatre. I'm a maternal fetal medicine specialist at Tufts Medical Center and the MFM Fellowship Director at Tufts. And we have such a great session for us today, very special session. Why don't you introduce us, Vincenzo?
Yeah, so I've been dreaming about this for a long time, doing something special about C-section. We published a lot of papers about C-section in AJOG MFM in the Pink Journal. It's really a procedure that gets done so often. Mo, there are 135 million births now in the world, and if you think that over 21%, probably at least, are C-sections everywhere, that means 30 million C-sections a year. That means one C-section every second. So
Oh,
every
wow.
second, a C-section. So it's a very, very common procedure. And my guess is that it's not going away. I mean, it does help some women. It helps some babies. It's probably not for everyone, obviously, but one C-section every second, it should be done the right way. It should be done for the right reason. So let me show you actually our website to begin with this time. And Here it goes. Let me see. I'm having trouble putting it on. Let me share. Sorry. Well, I'll can show you the website in a little bit, but we have a special delivery collection now. If you go to ajogmfm.org, you will find this collection of articles on C-sections that we put together over time, and we'll keep on adding to this. But today we'll go over some article with Mo and show you how we have special collections actually on cervical length. We'll have soon one on cerclage. We have special collections on twins, on evidence-based labor. So it's nice that we publish article on a topic and then we kind of put it together. It's almost like you have a little book of the latest evidence for things. And the one we want to highlight today is on cesarean delivery. So why don't I just do that? The first article, and we presented this before, but to remind you, it's a comparison of planned C-section versus planned vaginal delivery, randomized studies. And there are actually randomized studies, believe it or not, that women agree to having either a planned C-section, a planned vaginal delivery. You can tell me about the third breech trial, the twin trial, large trials like that. As you can see, over 6,000 people randomized, and at the end, they showed that perinatal and perinatal mortality was the same. But there's actually some benefit with planned C-section in the last column there on the right in terms of neonatal low umbilical pH being decreased with C-section, less need for tube feeding, birth trauma, hypothonia, and the mother, obviously, if you don't go to labor, you have a planned C-section, less choreo, less urinary incontinence, painful perineum, and breastfeeding at 1 month. But breastfeeding later on was the same. So I think breastfeeding was about the same on both when you look at longer term. But obviously with C-section, these are some older trial, more of a need for general anesthesia, uncommon, but more common compared to vaginal delivery. And you can imagine more wound infection since you place a C-section wound there. So interesting data for Todd. And there's actually an ongoing RCT based on, not ongoing, but planned RCT that we're going to collaborate on to compare planned C-section and planned vaginal delivery, even in nulliparous term cephalic patients, singleton patients. Next.
Yeah, and this is a great segue into an editorial that Vincenzo wrote along with about trying to study this, right? So we know that our patients are, many of our population is getting older. They may have additional comorbidities. They may not plan for having as many children. And so while we worry about the risks of placenta accreta with repeat cesarean sections and the complications that were just discussed between planned section versus planned vaginal delivery, we're truly trying to figure out what might be the best mode of delivery for these NSTV, the nulliparous singleton term vertex pregnancies. And there is really a call to action to try to evaluate not only the short-term outcomes, but long-term outcomes across the reproductive age for that particular patient. And so what the RCT has been proposed is looking at AMA patients, so over 35 years old, with these NSTD pregnancies who are not planning to have large families of less than 2 babies is their goal, and having a planned delivery at 39 weeks for either planned cesarean or planned vaginal delivery, and looking at a very large composite outcome, both for the perinatal morbidity and mortality, as well as maternal morbidity and mortality outcomes, as well as a number of secondary outcomes, both short-term and long-term. And, hopefully this will answer the question in a very evidence-based way and robust study design to give this answer. And so looking forward to this RCT in motion, hopefully soon. But more to come with that. But a really nice paper by Vincenzo and colleagues about this need and potential ways to study it.
This is kind of a review of the literature on obstetrical provider preferences for cesarean section or maternal requested and complicated pregnancies. And I want to thank Dr. Tanvi Rana again for leading this effort. The question that this 34 studies pose to midwife and OB providers, just like you and I, was if you had, nulliparous term singleton vertex pregnancy, would you prefer a cesarean delivery for yourself, for your close family member, or if you have already had such pregnancy, did you choose cesarean and delivery or maternal request? And to our surprise, we saw actually obstetricians, 14% of them would have would prefer cesarean delivery or maternal request, and if the baby was larger, even more. For a close family member, as you could see, 67%. But the most amazing thing at the bottom of the right beautiful scheme you came up, if these obstetricians had pregnancy themselves in the past, low risk, 1 in 4, 25%, actually did have a cesarean delivery or maternal request, while the midwife, as you could see, really didn't elect for that unless the baby was big. Kind of food for thought, and this was actually going up in the literature, in the last 30 years, this incidence of 25% keeps on going up. So it's interesting that whatever we're reading in the literature and scientifically we're discussing, a lot of people, and these are also residents or young obstetricians, electing more and more to have cesarean delivery or maternal request.
Very interesting. All right, we're going to next present 4 papers, different parts that have been written by a few authors who have been looking at a review in the literature, really thorough review of RCTs, systematic reviews, and meta-analyses, looking at the various steps of preoperative, intraoperative management, and postoperative management after cesarean delivery. And we're going to just present some infographics about these papers. The first part is the preoperative management and really trying to identify ways to improve maternal and neonatal morbidity and mortality. And so before the patient even before the case starts, things that have been found to be evidence-based improvements is encouraging an at-home body cleansing, just a shower with either soap or an antiseptic agent. The evidence seems to support only needing 1. You don't need additional cleansings before the OR. In terms of hair removal, shaving definitely seems to increase the rate of surgical site infections and discomfort when the hair regrows. So clipping is recommended if you're going to remove the hair, much more than shaving. The ERAS literature has also supported changing our plans before, or recommendations before surgery. So now clear liquid diets can be given to the patient up to 2 hours before surgery, and a light meal, which is defined as toast with clear liquids, can be given up to 6 hours pre-op. And in non-diabetic patients, pre-op carbohydrate drinks seem to improve their well-being afterwards, seems to decrease maternal insulin levels and improve neonatal blood sugars preoperatively. So that is recommended in non-diabetic patients. And there's no evidence that a bowel prep preoperatively improves bowel function or reduces ileus. So that's not recommended. In terms of medications in the OR, we do know that rather than waiting until after cord clamping, which was historically what we did for antibiotics to decrease infections, it's really the preoperative, 30, 60 minutes before the surgery of weight-based cefazolin, as well as adding a Zithro if the patient has been ruptured or is in labor. There's some evidence to support using preoperative IV gabapentin to improve pain scores, and doesn't seem to increase sedation, although it doesn't change your opioid use afterwards. Prophylactic TXA, especially for high-risk patients who are at high risk for postpartum hemorrhage, but can be considered universally in some practices. And we really don't use cell salvage routinely or oxygen routinely. So those are not found to be evidence-based practices. When the patient's on the OR table, we all want to use mechanical VT prophylaxis with our SCDs. And a Foley is actually not required. The evidence is showing that, which was very interesting to me, because that was certainly something that is done at the institutions that I trained at. But in low-risk patients, it seems to not, it prolongs the time until void and may decrease the chance of urinary retention, but has no change in the rates of UTIs. So not necessarily required for C-sections. And as we all do, the left lateral tilt and manual displacement is much preferred compared to a right lateral tilt in terms of hypotension. Music's been found to improve patient anxiety. Just make sure that the level is appropriate in terms of volume so that teams can still communicate safely. And then importantly, the temperature of the room is very helpful for decreasing neonatal hypothermia. So we want it over 77 degrees Fahrenheit for infants less than 32 weeks, and then about 73 to 75 degrees Fahrenheit if you're greater than 32 weeks pregnant. Non-adhesive drapes are helpful, and a surgical timeout, as we know, is very important for ensuring safety and improving outcomes.
And, I want to thank Daniel McKean. As you can see, she's the first author here. We've been collaborating for a long, long time on this issue. And I want to congratulate, the hundreds of authors who have published randomized studies on all of these issues you just talked about. And so it's just important to know them. So if you look at these articles, you will see that, what Mo and I are talking about is not our opinion. We're just presenting data from those randomized studies, systematic reviews. So to continue the preparations and technique of C-section, it's certainly beneficial to have a support person at bedside. Decreases patient's anxiety, increases satisfaction. Having clear drapes so that the patient can see the baby coming out, having a support person to cut the cord, doing the family-friendly C-section is so important. and so having at the end of C-section immediate skin-to-skin for 30 minutes or more in the OR, again, all associated with benefits for the mother and the baby. When you start the C-section, now we know that a transverse skin incision is best. Probably doesn't make much of a difference. Fanestill or Joel Cohen. We'll see later on another article that will talk about the Fanestill maybe being a little bit better for those with BMI over 35, but really not enough to say that one is better over the other. There's really no good evidence to cut the rectus muscle or during an inferior dissection, so you could avoid those. And also, there are many randomized studies now on the fact that you can avoid a bladder flap. It's associated with a little bit less pain, less bleeding, etc. So I've been avoiding doing a bladder flap for probably 15, 20 years now.
Yeah.
In terms of once you get to the uterus, allotransverse hysterotomy with blunt cephalocaudal expansion, it's best. It's associated with less extensions, less bleeding, infection, etc. The head can be delivered manually. Just make the incision, big enough for the head, usually a term C-section, and don't struggle. I hate when people have to use the vacuum or forceps or anything like that. I really think just make the incision big enough, safe enough. If the head is impacted, maybe she's been pushing for a couple hours, the head is really low. Reverse bridge delivery seems to be the best for that. It's sad to say that 3 out of the 4 trials on the fetal pillow were actually fake and not trustworthy. So that needs to be studied a little bit more. I'm not against it. I want to make sure people are aware of the data. The layer cord clamping, even a C-section, it's very safe. The mother doesn't lose more blood in the randomized studies that evaluated this. And so we usually do it for 60 seconds. And there's a lot of evidence for that. It benefits term babies and in particular preterm babies. And then you don't need to go in with your hand and take the placenta out like I was taught when I was a resident many years ago. You can just put some gentle traction on the cord, massage the uterus from the outside, and let the placenta come out spontaneously. So lots and lots, hundreds of trials on this evidence.
Excellent. And continuing on, so now between the placenta delivery and the skin closure. So I certainly was trained to do the sponge curettage after placenta delivery. But what the studies show is that it may actually increase the rates of endometritis and doesn't seem to improve the chance of retained products of conception or change the chance of the degree of blood loss. So it's not really needed at this point. The evidence doesn't support that. Also, mechanical cervical dilation was thought to decrease the chance of retained lochia, and that hasn't really been shown to be supported by the evidence. There's a lot of great studies published in this review about the various techniques for uterine closure. And so I didn't put all of them in this infographic here, but there is a suggestion that, full thickness, double layer closure of the uterine of the hysterotomy may improve the myometrial thickness and also may decrease the rate of the niche formation, which we know is sometimes suggested to be a risk factor for placenta accreta syndrome. And so, a number of people are now encouraging to incorporate the endometrium when we do this double layer closure. Also is changing the gloves before closing the abdominal wall. So between the delivery of the placenta and before you close the abdominal wall, changing the gloves appears to decrease the rate of surgical site infections. The largest RCT on this did it after the uterine closure, and a lot of surgeons may feel more comfortable with that just to make sure that our bleeding is controlled before taking the time to switch gloves. Intra-abdominal irrigation is not recommended. It's been found to increase the rates of intra-op and post-operative nausea without improving outcomes. And also adhesion barriers, which I think is very common in GYN cases, has not been shown to actually improve the rates of adhesions in C-section. Therefore, the data doesn't support that. Closing the peritoneum and rectus is something that was certainly popular when I was getting trained, but now the data is showing that that is not improving outcomes and may actually increase postoperative pain, especially for vertical fascial incisions, close fascial bites, so between 5 by 5 rather than the traditional 1 centimeter apart, has been shown to improve the rates of or reduce rates of hernia. And then in the skin closure, we have presented some papers in our prior sessions about skin subcutaneous layer closure. The data supports closing it when this layer is over 2 centimeters, and irrigation is helpful in decreasing surgical site infections, but putting in drains is not really found to be helpful. Closing of the skin with monofilament sutures has been shown to be better than staples, and avoiding multifilament sutures as well is important. And then usually, there's a lot of different kinds of gauzes available and dressings available. The data supports using these DACC impregnated dressings, but if you don't have that available, the data does not support using a plethora of other. You should just be using standard gauze if you're going to use a dressing at all. So here are some tips for this part of the procedure.
And immediately post-op, if the patient is obese or didn't get pre-op azithro, you can consider additional antibiotics. Also, if the blood loss is over 1,500 cc's, or obviously, if there is already chorioamnionitis and intraamniotic infection. We already discussed the fact that you really don't need a Foley during a C-section. There are trials comparing Foley to no Foley, showing better outcomes. But if for whatever reasons you're still using it, you can take it out right after you finish the C-section. There are actually many randomized studies on chewing gum at C-section and doing it, I think, at least 3 times a day for 30 minutes has been shown to decrease time to appetite, decrease the time you go home, increase the time you pass gas and move your bowels, and so much quicker recovery of your GI tract. Also, schedule Tylenol and NSAIDs. You can go from Toradol beginning, maybe ibuprofen after, has been shown to not only improve pain control, but also decrease the use of opioid. Actually, one of our faculty, Dr. Bender, is doing a randomized study now comparing doing the Tylenol and NSAID at the same time versus staggering it.
Yeah.
Which I can't wait for results. I apologize for my cough. I do have the flu, I think. You can certainly give short-acting opioids for breakthrough pain, but with gabapentin, Tylenol, NSAIDs, etc., very little need for opioids these days. Let the patient ambulate as soon as possible, but continue mechanical VTE until she ambulates freely, and give Lovenox for high-risk patients. And you can move the patient through recovery pretty quickly. Man, I need help.
You want me to take it?
Let me finish this slide quickly.
Okay.
Start eating solids within 2 hours of C-section, which is really a big change. There are meta-analysis of randomized studies showing that's good. Again, ambulate 4 hours after a C-section. Now the Foley's out, you feel good, and you can even be discharged certainly at 48 hours in 2 days. But if the baby's going to be followed up closely, even at 28 hours after a C-section. You don't need to give many opioids. You can certainly calculate how many she has had and give as little as you can, if any. For discharge, cancel an inter-pregnancy interval, and obviously encourage contraception and exclusive breastfeeding for 6 months. So we just gave you a huge quick summary on hundreds of randomized trials, of many meta-analysis. There's a lot of evidence on how to do a C-section, and I really thank you, Mo, for this beautiful infographics.
You're welcome. Okay, I'm going to touch on this article that Vincenzo briefly introduced. We've presented this one in the past. This is looking at trying to find out what is the best surgical approach for patients with a BMI over 35. And you can see here, there are kind of two methods that this study group was doing. This was at Jefferson. The Cohen incision is 3 centimeters in a transverse fashion below the anterior superior iliac spine, and you leave the pannus as is without retracting it, versus the fan and steel, which is retracting the pannus and then having the fan and steel incision 2 centimeters above the pubic symphysis. And the group was trying to evaluate in this RCT how the Cohen incision compared to the fan and steel incision could improve a composite of maternal morbidity. They had planned to recruit a significant number of patients. I think they needed 128 per arm, or something close to that. Unfortunately, given the recruitment time, they were over 42 months, they were only able to recruit 34 in the Cohen arm and 38 in the fan and steel arm. So about a third of the intended sample size. So the trial did need to get stopped early, which may have resulted in underpowering and obviously difficult with analysis. But of the patients who were recruited, the patients who had a Cohen incision did not have any difference in the composite maternal morbidity, regardless of the degree of obesity. There was a longer time in skin to delivery, a lower 5-minute APGAR score, and lower physician satisfaction. And it seems that, they seem to be similar outcomes. And at this point, I kind of defer it to the surgeon with their preference, just because there wasn't that much a difference in their outcomes for this approach.
Yeah, and I want to thank Dr. McCurdy, who was our fellow at the time in the wind, and the one who did all the work. So this article talks about myomectomy at the time of cesarean delivery, not being associated with transfusion. It's always a question that comes up. We're all taught, don't touch those myomas, when you're doing a C-section. But interesting enough, here they didn't find too much difference. Obviously, cesarean delivery and myomectomy was associated with a slightly longer OR time. DBL was 800 versus 700, and transfusion 7% versus 0.7%. But there was no change in pre-post hemoglobin or transfusion based on fibroid size. So the message, I think, don't do a myomectomy at C-section, but if it's, in the way, maybe epinucleated fibroids, maybe it's in the incision and you can avoid it, and the fibroid seems to be coming out at some time, you may need to do a myomectomy in some patients.
This is a placebo-controlled RCT that was performed in India to look at the effectiveness of phenylephrine infusion in postpartum blood loss. And so, we know that postpartum hemorrhage affects so many patients, higher chances in cesarean section, especially in low resource settings. And so we know that alpha adrenergic agonists do contract the uterine smooth muscle and also constrict blood vessels. And so the hope was that using phenylephrine, which is used so often with patients who are receiving a spinal anesthesia, to see if this was actually going to affect the postpartum blood loss rates. So in this RCT, they took low-risk patients who were undergoing a C-section, and before the spinal anesthetic was introduced, the patient began an infusion of either phenylephrine or normal saline. They got their spinal, and then they proceeded with the C-section and quantitated the blood loss. What they found is in the patients who were randomized to the phenylephrine arm, they did have decreased quantitative blood loss, but the amount was very small in terms of the differences, 74 cc's. Interestingly, though, they had significantly lower rates of blood transfusion and less hypotension, obviously, from the phenylephrine. And so, the way I interpreted this data was that the clinical, the blood loss itself was a small difference. However, this patient population had significant rates of severe anemia. And so in cases of maybe low resource settings or a patient population that has starting out with a baseline anemia, this might be helpful actually in decreasing significant postpartum blood loss and rates of transfusion, but may not be applicable in all of our patients.
This is looking at maternal and neonatal outcomes after delayed versus early cord clamping at C-section. We touched on it, a little bit earlier on. Again, a meta-analysis of trials, and you can see that there were benefits to delayed cord clamping even at C-section. There was no increase in postpartum hemorrhage, blood transfusion, additional uterotonics, hysterectomy. So it's safe, if you look at the maternal outcomes. And in terms of neonatal outcomes, obviously, the hematocrit was better, etc. So they concluded that delayed cord clamping, usually 30 seconds, 60 seconds or more at C-section can be safely performed and improves neonatal outcomes. There's a lot of data on vaginal delivery as well, but we're talking about C-section today, and it's nice to see a meta-analysis just on C-section.
All right, and this is looking at early wound dressing removal after cesarean delivery. This is a meta-analysis of RCTs. We have presented this before at one of our monthly issue highlights. There's a lot of kind of back and forth about, when to take off a dressing. Some people don't even put a dressing on after a C-section, but those who do, the question is, do you want to keep it on longer? Because that's hypothesized to maybe improve wound healing. Other people suspect that, keeping it on for a significant time may actually increase the moisture and make it bad for wound healing. So this was a meta-analysis looking at the RCT data available. And it compared having what they called an early removal, which was less than 24 hours, or having a late removal of at least 48 hours post-op. And they found that removing it at least 24 hours post-op did not increase the rates of infection, wound disruption, creation of a seroma or hematoma. And actually, one trial was studying patient satisfaction and showed an improvement in patient satisfaction with early removal. So it does appear that removing the dressing at least 24 hours or within 24 hours post-op does not seem to affect wound outcomes and may improve patient satisfaction. And keep that in mind on our postpartum rounds.
And I think that trial was the one that looked at 6 hours versus 24 hours of, taking it out in terms of patient satisfaction. So based on that, again, there's not too much data. I tend to favor, taking it out as early as 6 hours, if you put it on at all. This is the thing we were mentioning before about early hospital discharge after C-section. There are actually 7 randomized studies, as you can see here, over 4,000 patients randomized. Again, they were slightly different, but usually early was, less than 48 hours, and later was 48 hours, more than 48 hours. Early discharge, meaning as early as 24 to 28 hours, was associated with no differences in maternal readmission or complication, which is what you want, right? If you think you're going to send somebody home that early, maybe she needs to come back, later because of some concern to the wound or fever or whatever. And actually, there was no difference in readmissions or complications. There was an increased neonatal readmission rate if a patient was sent home that early. So I think that the message there is that the baby needs to be checked. If the mom goes home day one, the baby should see the pediatrician, or the pediatrician should go see the baby at home. There should be some check to make sure bilirubin and other things are good with the baby, because otherwise there's an increased rate of neonatal jaundice. If you discharge at 48 hours, so day 2, then neonatal maternal outcomes are the same. So it's super safe to send at 48 hours. And it's really becoming our standard here at Jefferson to send uncomplicated C-sections on day 2. I forgot if I mentioned this, Mo, the first time, but when we had our last baby 2 years ago, the C-section was done at 4 a.m. And at 4 a.m. the next day, the neonatologist was nice enough to come check the baby. And we actually left at 8 a.m. on day one, so 28 hours post-op. And again, it's different because, two physicians and, not the first baby, etc., healthcare workers, but that worked out well without complications. So we actually witnessed the benefits of and parent satisfaction of being discharged 28 hours after C-section ourselves.
Nice. This is an RCT that was performed at Yale, evaluating lidocaine patches after cesarean section. We know that that's been shown in laparoscopy cases at the site of those laparoscopic incisions to improve pain scores after surgery. And so this group wanted to evaluate looking at it after cesarean section. So they took patients who had either the first, second, or third C-section and randomized them to receiving a daily lidocaine patch that was placed superior to their Faden steel incision, or a placebo patch, which was actually created at the institution, and they had that. And they then had routine post-op care. Interestingly, this institution routinely does tap locks post-op. So all the patients, or I should say the majority of patients, received a tap lock as well. The study did not find any difference in the pain scores, although 63% of patients enjoyed having the patch on. But I suspect that that while I didn't see a difference in pain scores, it probably was confounded by the tap lock, which targets the similar kind of response. And so it would be interesting if they were able to repeat the study without the tap block and really compare if there was a difference. I'd be curious to see what happened, but certainly an interesting evaluation of another kind of mode of pain management.
Yeah, if you think about it, Mo, there are so many options, to make post-op after C-section, pain-free almost. We talked about NSAIDs, we talked about Tylenol, you talked about gabapentin, tap block is certainly evidence-based, binder, may be helpful. There are many infiltrating lidocaine or novocaine, whatever, during the C-section in the fascial area may be helpful. There are many things that work, and the message here is to think about those routinely, maybe lidocaine patches, and avoiding opioids instead, and getting people addicted to those. I think this is the last article for us. This looked at fixed time interval and on-demand anesthesia protocol for C-section pain, and looking at long-term effect. It was a telephone study of participant looking at fixed time interval versus on-demand pain meds, and fixed time interval pain meds were associated with less chronic pain and less even pathologic behavior in children, which is amazing that they looked at that. Nice to see, follow-up of randomized trials long term. So we definitely know now that we need to give this medication, like again, Tylenol, NSAIDs, around the clock, fixed, especially for the first 2-3 days, all the time. Don't wait for the patient to complain, but cover their pain kind of prophylactically as prevention all the time, which has been shown to be evidence-based, and this just confirms it. So lots of evidence on C-section. Thanks, Mo, for having a longer session today. We really wanted to highlight this special delivery special edition. I'm glad I survived my flu and I could talk some. Mo, why don't you close it up?
Yeah, thanks so much, everyone. These were infographics, but you can read and I encourage you to read all of the fantastic work on AJOG MFM. You can read the papers in detail, but really excited to share evidence-based practices. Hope you can include and incorporate them into your own practice. But we'll see you next time for our usual monthly highlights, and have a great day.
Bye-bye, everyone. Have a good day.